Good afternoon, ladies and gentlemen. I think the idea of looking back is a very sort of opportune one, because in fact I look back literally to exactly 10 years ago this month in a gathering very similar to this in a conference center here in Abuja, where we witnessed the launch of the National Health Insurance Scheme by President Obasanjo. That was June 2005. And actually, at that time, or on that day, the president gave all of us who were actors and who were participating in the process a very clear mandate, and also what was very much a challenge, which was to achieve universal coverage by health insurance for Nigerians in 10 years by 2015. So it's really, can I say, timely that we're here exactly 10 years later, and we can look back to see what have we really achieved. And I think for me, that's the big sort of missing piece, what we haven't achieved with such an opportunity that was presented to us. I mean, the president even did quite well in making the work, in a way, a little bit even easier for us, because that day, he actually took pains to stratify the population of Nigeria into what he saw as 5 groups who would need special attention or different ways of approach in terms of really scaling up the insurance risk pool. And those groups were the formal sector, the informal sector, the under 5s and aged, the poor and vulnerable groups, and, well, he had a personal constituency of what he called the prisoners, because he had just, at least before becoming president, he had obviously spent time in our jail system. But, it was, so he said, look, this is it. This is going to be the challenge. Each group is going to have their own specific, requirements when you think about how to cover them. Here's some money. So he put money on the table to say, let me start the process of funding by funding the federal civil servants and their dependents. Go and get started, go forth, as it were, and try and make this thing multiply. And of course, all of us who were and still are big believers and proponents of a health insurance system saw the key benefits, the key advantages, the key necessity of having a scheme like this really flourish in Nigeria. We saw the fact that we really needed a system on healthcare, of financing healthcare in a way that would create social protection and equity. This particularly because, as at that time, and still not so, we haven't moved too far away from where we were then, but we had a situation where healthcare was being funded. 2/3 of funding of healthcare was happening from private out-of-pocket spend. And that's still what's happening today, more or less. It's shifted slightly, but only slightly. So the people of Nigeria are the ones really dipping their hands into their pockets to fund care when they need it, as opposed to, a fully funded government system or anything else. And that really in itself creates or has created what we would call the inverse relationship between those who need care most and those who can afford it. Because it's, the law of averages is always that those who need it are the ones who will become impoverished in trying to afford it. And that was a specific issue. The other issue too was organizing and integrating care. And I know we'll talk about that from the point of view of primary health care and so on. But we also see it from an insurance point of view that can deliver a benefit package that integrates care. And that was exactly what was put on the table by NHIS at that time. It was an integrated benefit package that covered primary health care, covered maternal health, child health, malaria, and in fact, we then struggled and did quite a bit of work about a year later to also cover HIV/AIDS within that package. And that was really, where we thought we would therefore be able to see the integration of the primary health system come together with a funding system that supported it to really move that forward. And then, of course, there was the role of the private sector, which was really coming into the fore with the PPPs of the HMOs coming in to help to run the scheme. And that did two things. One was, yes, it brought private players into the mix, but it also brought private investment in a very serious way. It brought private investment into the insurance pool, but it also brought private investment looking now to invest in health services and health facilities in what we call the supply side. Because the main thing any investor looks for in any market, whether it is healthcare or otherwise, is that there is a market. And we realized that we did need to do some work to make it plain that healthcare was a market that people could participate in, whether they were in a rural village or whether they were employed or whether they were, running their own businesses. But they could all join into that marketplace, which investors could then put money behind to really help to improve standards and the quality of the infrastructure to look after them. But really, having said all of that, today, I think Chikwe started by saying we're not even sure of the numbers of people covered. The number I have is 6 million people, and that's between what is covered by the NHIS under the government pool, what is covered through various pools for the poor and vulnerable groups, what is covered in what we call community health insurance, and what is covered in organized private sector schemes, private insurance schemes. But 6 million is still a very, very far journey from what we are aiming for, which is full coverage. And I think there's been some key flaws in the system that have led to, at least the fact that this hasn't grown. Certainly one was very quick, I must confess, proliferation of HMOs. We started as 8 HMOs. Within a year or so, there were 75 licenses, which meant straight away the risk pool just got fragmented. And once the risk pool gets fragmented, the investment required, everything required to keep the system moving and to create scale just fizzled out. The lack of regulatory muscle. We had an NHIS which wears many caps, a fund holder, a program manager, and then even a regulator. And sometimes those caps, I'm not sure how well they really thought through a key one, which was regulation. Regulation of the activities in itself in the insurance space, and of course the regulation of the providers, the hospitals who were actually giving care. And that really created what I'll call a trust deficit. The population just did not trust the system, did not trust the quality of care that they got when they were covered, did not trust the HMOs. And that is a legacy issue now that we have to overcome. And then, of course, the issue that was raised before of lack of accountability, the fact that up to today, the NHIS itself has never published an annual financial account. So as far as we are aware, has never been audited, even though it is there in the law, which set it up in 1999. And then, of course, finally, government just has not put enough money on the table, particularly when we look at the vulnerable groups, the poor, the under fives, and the aged, the bottom of the pyramid. Those numbers, the bottom of the pyramid who need subsidy will probably be somewhere in the region of 75 to 80 million people. And really, the amount of funding that's required, the government also has to make a very sort of serious commitment to it. So where we go from here, as I said, yes, one is the serious commitment that we need in terms of funding from government, helping that to galvanize again the private sector to put more money into the system. We feel that there's at least 30 to 40 million people who can afford it through private means and can therefore create a bigger market, which again can help to spur on investment in the hospitals and clinics and facilities that we need to see. And finally, address that trust deficit, which now is not just between the public sector and the HMOs and the insurance space, but is also with, as I think we just heard from the last speaker, the healthcare workers themselves, where we also really need to make sure that they are also part of this process, they are also accounted for, and they also see the benefits, shall I say, of really putting together a universal coverage driven by insurance and risk pools. Thank you very much.